A child may develop pulmonary hypertension for a variety of reasons. Some may be diagnosed at birth due to congenital heart disease or lung disease or through genetics. And in some cases, similar to adults, there may not be a cause for a pediatric PH diagnosis. During this episode, we will reference our first episode, Filling in the Blanks, Understanding Pulmonary Hypertension, Part 1, featuring Dr. Jenny Yang. If you have not listened to that episode, please take a moment to go listen and then come back to this one. In this episode of PH Insights, we'll hear from Dr. Paul Critser and learn what parents and caregivers should know about pediatric PH. Welcome to PH Insights, presented by the Pulmonary Hypertension Association. Join us as we delve into patient stories, healthcare updates, and the latest insights on pulmonary hypertension. Hi, it's Angela, and welcome to this new episode of PH Insights. I am so happy you are here listening with us today. I am also equally excited and happy that Dr. Paul Critser, who is the Assistant Professor of Pediatrics at Cincinnati Children's Hospital Medical Center, he will join us today to discuss pediatric PH. Dr. Critser, thank you so much for being here today.
Thank you, Angela. I'm really excited to join you for this podcast. I think it's a really important topic, and it's great to be here to talk more about information for kids with pulmonary hypertension.
Yeah, that's exactly why we wanted to do this. We want to have some information for the parents who may be navigating a pediatric PH diagnosis. I know in a previous episode, like I mentioned before, we spoke with Dr. Yang, and she gave us the standard definition of pulmonary hypertension as high blood pressure in the lungs. Can you elaborate on that or explain it for pediatric PH?
So like in adults, pulmonary hypertension in children and teenagers causes elevated blood pressure in the pulmonary arteries. So the definition of pulmonary hypertension is a mean pulmonary artery pressure greater than 20 millimeters of mercury. And that's the same in adults as it is in kids. But we also focus on the pulmonary vascular resistance, or how hard it is for the right heart to pump blood through the lungs. And there are slight differences in the values of what an elevated pulmonary vascular resistance is in kids and in adults. And that's because kids are growing all the time, and we need to account for their size when evaluating the resistance. There's also differences in causes of pulmonary hypertension and some of the ways that we treat them. And we can talk more about that a little bit later.
Yeah, it's interesting, and I'm throwing you a curveball here. I didn't think about as the child grows that pressure changes. Honestly, that didn't even register to me that the pressure could change, so there could be a delayed diagnosis.
Yeah, so I think it's important to clarify that the diagnosis of pulmonary hypertension is based on an elevated pulmonary artery pressure, and that's the same no matter what age the child or the adult is. But we do know there are some differences in what a normal pulmonary artery pressure is across the lifespan. So when babies are first born, there's a period of transitioning, and the pulmonary artery pressures are high initially in that first month or two of life before they come down to normal levels. But we do think about the resistance, or again, how hard it is to pump blood through the lungs a little bit differently. And that's because as kids are growing and their heart and lungs are growing with them, we have to account for how big they are in terms of the measurements that we're making and what that vascular resistance measurement is.
That definitely makes sense. As you explain it, it just for a moment, I was like, wait, I didn't even think of that. And I think parents may have a similar thought as they are listening to this episode and trying to understand how to talk about this with their medical team and be able to understand the language that will be used when they are in those appointments. Dr. Yang also mentioned the 5 hoop groups. Are these the same? Are there different types of
pediatric PH?
Yes, great question. So PH is classified into 5 groups based on what's causing the pulmonary hypertension. And this classification or groups are the same in both kids and adults, but there are some very important differences in what causes pulmonary hypertension depending on how old someone is. So in group 1, pulmonary hypertension or pulmonary arterial hypertension, In children, the most common causes is due to genetic or heritable causes, with certain genes such as TBX4 and SOX17 being more common in children. Also, congenital heart disease is much more common in kids and something that we have to think about, as well as persistent pulmonary hypertension in the newborn, or sort of a delay in transition of those pulmonary pressures and resistance to normal levels after a baby is born. Group 2 is PH associated with left heart disease, and heart failure is a common cause in adults, but this is much less common in children. But we do look for things like pulmonary vein stenosis, which can cause obstruction to blood flow and pulmonary hypertension in children. Group 3 is lung disease or hypoxemia, low oxygen levels. And this is really a major cause of pulmonary hypertension in children. In fact, in the Pediatric Pulmonary Hypertension Network Registry of children with pulmonary hypertension, this group 3 pH was responsible for almost half of all kids. And this can be caused by children being born preterm or early with developmental lung disorders or genetic syndromes, including Down syndrome. Group 4 pH is obstruction of the pulmonary arteries. This is often due to pulmonary embolism or chronic thromboembolic pulmonary hypertension. And while this is common in adults, this is much less common in children and not something that we see very often. Group 5 is multifactorial causes. This is an important category for kids who have complex congenital heart disease, including children and teenagers who have single ventricle heart disease and who've had a Glenn or Fontan surgery. This is really a growing population of kids who may have pulmonary hypertension or pulmonary vascular disease.
I know we're going to talk about treatments and diagnosis, but if you have congenital heart disease or any of the other conditions mentioned, is it instinctive for a pediatric medical professional to request testing for pH?
So all of those things that we talked about put kids at risk for pulmonary hypertension, but it doesn't necessarily mean that they will have pulmonary hypertension. So having congenital heart disease, for example, is a risk, but many children with congenital heart disease don't have pulmonary hypertension. But it is important to know. Kids who are born early and who have developmental lung disease, and in particular bronchopulmonary dysplasia, those kids should be screened with an echocardiogram or heart ultrasound at a certain point of life to make sure that we're not missing signs of pulmonary hypertension or high lung vascular pressures. And that really is a routine practice, and all parents should expect that their kids would receive that type of testing.
I think that is an important note there. There's a lot going on, especially if your child is experiencing any discomfort, for whether you're a new parent or this is, your third or fourth child, but just to know in some of these cases, these things are routine. And you did mention the echocardiogram. I think that will lead us into the diagnosis of pH in the child. Can you elaborate a little bit more on that?
Yes. So the first thing to say is it's important for kids in particular to do a comprehensive evaluation to really understand if there are other causes of pulmonary hypertension. And this involves a number of tests that may be recommended by the healthcare team. Often, the first test that raises concern for pH is an echocardiogram, this heart ultrasound. In children, it's important to look at the heart anatomy to evaluate for any congenital heart disease, residual holes in the hearts, or narrowings that could cause these elevated pulmonary pressures. It also helps to assess the size and function of the heart chambers, and we can really see signs of elevated pulmonary pressures on the echocardiogram. Again, children who are born early or who have other diagnoses may need to have a screening echocardiogram as part of their routine care, and parents and caregivers should talk to their team about it. The diagnosis of pulmonary hypertension should be confirmed by a cardiac or heart cath in most children. This is a procedure that measures the pressure and blood flow in different chambers of the heart and the pulmonary arteries, and really serves still as the gold standard for diagnosing pulmonary hypertension.
You say in most children, is there a particular age or age range that is required for that cardiac cath?
Yeah, I think for children who are born early, who are small, or who are very sick, it may be reasonable to wait and do a heart cath later. and go ahead and treat for pulmonary hypertension based on other testing, including the echocardiogram. But for most children, particularly who are older, school age or teenagers, if they have evidence of pulmonary hypertension by an echocardiogram, really a heart cath is the test that should be done to confirm the diagnosis and to help guide treatment.
I think that, again, I feel like everything is important to note. I feel like I say that a lot on this podcast, but again, when you are receiving just a lot of information about a rare condition you're not familiar with, just being able to have the terminology to understand the steps or the things that you should ask for or know that your child should receive will be helpful to parents and caregivers listening to this episode. Do you think that parents or caregivers should advocate for these additional tests at a certain point, or is there a way you think that they should go about that to ensure that their child has an additional test to confirm diagnosis?
So pulmonary hypertension is a rare disease and a rare diagnosis, and it's common for kids in particular to have symptoms for a period of time before they have diagnosis made. So I think if parents have concerns, if there are signs and symptoms that suggest their child may have pulmonary hypertension, it's important to talk with their doctor and their treatment team about getting evaluated. Again, an echocardiogram is usually the first test that helps to screen for pulmonary hypertension. And if that shows signs of pulmonary hypertension, then talking more with their team about if a heart cath is indicated for their child would be important.
Yeah, I think you transitioned me greatly to this next point, which is very important. The signs and symptoms in a pediatric patient. What are parents, what are doctors looking for?
Mm-hmm. And as a common theme is that the signs and symptoms is going to depend on how old the child is. And so it's going to be different if they're a baby or if they're a younger child or they're a teenager. In kids and in teenagers, the most common symptom is being short of breath, particularly with activity, whether that's playing with friends in the backyard, in school, at gym class, or while playing sports. Kids can also be more tired, have less energy, and not just be just not as active as they once were. There are other symptoms that are less common, including chest pain, palpitations, or swelling, which we can see. And babies, it can be a little bit more difficult to diagnose or to recognize these symptoms. Again, we focus a lot on their breathing. Do they seem to be breathing faster or harder? Are we concerned about their color, looking pale or blue? Or are they having difficulty with feeding and growing? The challenge is that these symptoms are not very specific for pulmonary hypertension and can be due to other things. And this is where talking with your healthcare team can be important. Again, many of these symptoms are subtle and develop over time, which is why it's not unusual to take some time before children are diagnosed with pulmonary hypertension.
I think one of the aspects of this and receiving that diagnosis is weeding through if it's something else, which is hard to do. It's hard to wait to see if this is the diagnosis, but just making sure that it is accurate so that then your medical team can determine the best treatment options and the best treatments there are for if they have it associated to congenital heart disease. What does that look like? So what are some of those treatment options for pediatric patients?
The first and most important part of treating pulmonary hypertension is to treat any condition that may be causing or making the pulmonary hypertension worse. And in kids, there are several common conditions that we see. Lung disease, we already talked about, where they may have hypoxemia or low oxygen levels. Kids can also have feeding difficulties and aspirate or swallow food into their lungs, which causes inflammation and injury and may require some feeding therapy. Hypothyroidism or low thyroid hormone levels and some vitamin deficiencies can also make the pulmonary hypertension worse. So it's very important to test for all of those things and then treat them, because our medicines specific to pulmonary hypertension won't make those things better. There are some specific therapies for pulmonary hypertension. In general, there are 3 different pathways that these medicines can fall into, including the nitric oxide pathway, the endothelin receptor antagonist pathway, and prostacyclin pathway. And these are similar between treatment in adults and children. It's important to know that currently there are only 2 medicines approved by the FDA for treatment of children with pulmonary hypertension. Those are sildenafil and bosentan. But it's common for us to use other medications off-label to treat children with pulmonary hypertension. And it's important to talk with your medical team about these options. Usually children are treated with a combination of medications, and this really depends on the cause of pulmonary hypertension and the severity of the pulmonary hypertension. Medications can be given orally or taken by mouth. They can be inhaled, and some patients will need prostacyclin that's administered continuously, either through a pump through the skin, subcutaneously, or intravenously through a central line. There is a 4th pathway, a new drug called sotatercept that's recently been approved for treatment of PAH in adults. This is still being studied in children with pulmonary arterial hypertension. And this may be a treatment option, particularly for some older children, but it's important for parents or caregivers to talk with their healthcare team about their child to know whether or not this could be an option.
You mentioned that it's being studied. So a lot of times drugs, medications, they are tested or studied on adults through clinical trials. And there may also be options for pediatric patients as well, which you just mentioned. Is that something that parents should take an interest into determining a clinical trial that they can have their kid in? Do you advocate for studies with your pediatric patient?
Yeah, so clinical trials allows us to really understand what the best dosing may be, whether or not there are differences in side effects, and in some cases try and understand what the benefits may be for children. One of the challenges that we have is that, again, pulmonary hypertension is rare, particularly in children, and so it can be difficult to get enough families who are willing to participate in these studies. There are several studies currently ongoing looking at a couple different medications for the treatment of pulmonary hypertension in children. It's important to emphasize for families who are thinking about participating in research that research is completely optional.
Yeah, it's completely voluntary. I think that there's always fear or concern about joining in a clinical trial. Not participating in one, if you are asked, does not influence your treatment, does not influence your care at all. Thank you for sharing that information about the clinical trial process and what that would mean for a patient. We talked about the treatment options and medications. Are there surgical options for pediatric PH patients?
Yes. So if despite being on good medical therapy, the right heart and the pulmonary artery pressures are still very elevated, kids are still having a lot of symptoms, there are 2 surgical or interventional options that can make it easier for the right heart to pump blood and get the blood to the left heart and out to the body. One is an atrial septostomy, often done during a cardiac catheterization or heart cath. And this procedure creates a hole between the top chambers and the heart between the right and left atria. The second is a Potts shunt, and this is a surgical procedure that creates a connection between the left pulmonary artery and the aorta. And this is an option for children with suprasystemic pulmonary hypertension, meaning that the pressures on the right side of the heart are higher than the pressures in the left side. Now, both procedures provide a pop-off to allow the right heart to pump blood more easily by bypassing the lungs. The major side effect is that because some of the blood skips the lungs and doesn't get oxygenated, the saturations in the body will be a little bit lower. But this can be a good option for patients who are not responding well to medical therapy. The other surgical option is lung transplant. For families who are discussing surgical treatment options, certainly a Potts shunt or an atrial septostomy, we feel it's important that they also get information about lung transplantation to make the best decision regarding treatment options for them and their child.
You mentioned for one of the surgeries is typically done during the heart cath.
Mm-hmm.
So is that something that, and please forgive me on just trying to wrap my head around this, if the heart cath is used to diagnose, is there that question where if we do find it, do you want to immediately go to the surgery, or is it something where you're diagnosed during the heart cath, you have a period of time to then decide if you want to have the surgery for your child?
Mm-hmm. I will say that the practice varies a little bit by center across the U.S. The atrial septostomy is a procedure that can be done during a diagnostic cath. So there are patients who will have a heart cath to diagnose pulmonary hypertension, and based on the findings, they can have the atrial septostomy done at that same time. For other children, it may be that over time, if their symptoms evolve or based on how they're responding to therapy, that their medical team talks to them about doing a septostomy at their next heart cath.
And is there a long recovery process? Because if we are talking about children, especially if they're school age, if they
Mhm.
are in school and not homeschool, what would be the potential recovery time after surgery?
Mhm. So the atrial septostomy done during a heart cath has a fairly quick recovery, meaning that if a child is coming from home for a heart cath, that we would expect them to stay 1 or maybe 2 nights in the hospital before going back home. The pot shunt is a cardiac surgery or a procedure that has a longer recovery time, where we would expect children to be in the intensive care unit for a number of days and then spend several more days on a step-down unit recovering from the surgery before they would be going back.
So with the pot shunt, I believe you mentioned that could result in like low saturation of the oxygen levels. Does that mean that the child will then be on oxygen or need supplemental oxygen after that surgery? Is that for life?
So in general, after the pot shunt, the blood that goes to the heart itself, to the brain, and to the arms is very pink oxygenated blood, and we expect the saturations to be normal. The pot shunt sends the blue blood or desaturated blood down to the lower half of the body and to the legs. And so we expect that the oxygen levels, when we measure them in the feet, for example, will be lower by 5 to 10 points. Most children who didn't need oxygen before a pot shunt won't need oxygen afterwards, at least not long term. They may need it during the recovery from the surgery process, but our expectation and hope would be that they would wean off of that breathing support, including oxygen.
Thank you for elaborating a little bit on that. What are some other key concepts that parents or caregivers should know about managing their child's diagnosis? How should they even explain this to their child as well?
So the diagnosis of pulmonary hypertension can be very overwhelming. So it's very important for people to know that first, pulmonary hypertension in kids is different than adults. So don't start with Dr. Google. It's important to get information that's specific to kids. And that can come from your treatment team. A PHA and the Pediatric Pulmonary Hypertension Network have great resources for families. Secondly, parents and caregivers should know they're not alone. Their healthcare team wants to be there to support them through this journey. No question is too small. Please ask anything. We want to help you. There are also patient and caregiver support groups for pediatric PH. PHA has information. Your healthcare team can help connect you with these resources. They can be incredibly helpful. For parents and caregivers, they're taking on a lot with the diagnosis of pulmonary hypertension. So it's important that they understand what are the medications their child is taking. How and how often should they be getting the medicines? It's not unusual for kids to be taking multiple medications multiple times a day, and families will need to help create a schedule. Why we want kids to get all of their medicines every day, we know life happens and that a dose may be missed, but it's important to notify your team if your child has missed any doses, as we may need to adjust medication based on that. And certainly to notify the team if there's any interruption in a prostacyclin infusion therapy. For parents and caregivers, it's important to know the signs and symptoms that suggest pulmonary hypertension may be getting worse. Sometimes kids won't be able to tell you. And to know who to call or where to go if they're worried about their child. For kids who are school age, their healthcare team can help with resources for school and school nurses. PHA also has resources that can be helpful for schools regarding pulmonary hypertension and the medications that kids may be taking. The second half of your question was about how to talk to kids about their diagnosis. And this can be challenging. It really varies based on how old they are, how they are, where they're at in their developmental process, and it's an individual approach. Parents know their kids best and can help with this process in terms of how much and when. I will just say kids are smart, and they often know more than we give them credit for. Certainly by the time they're in 3rd, 4th, 5th grade and older, they are very aware of their symptoms and how they're different from their peers. So it is important to start to talk to them about PH so they understand what's happening. And just like kids without PH, children with PH can struggle with mental health, and particularly in the setting of having a chronic illness. So it's important to keep this in mind and ask your team about mental health and child life supports that's available at your center. Our goal is for kids with PH to grow up to be adults with PH. So as they get older, it's important to get them more and more involved in their medical care through appointments and being responsible for taking the medications, and eventually to start thinking about transitioning from their pediatric team to the adult care providers who will help them as they continue to live the rest of their lives.
We've talked about transitioning from pediatric to PH to maintaining your own care as an adult. And I think that is something that needs to be a focus right here in this conversation. It's so easy to, as a caregiver, as a parent, to want to ease the burden for the child, to let them live their life and have that sense of a normal childhood and retain all of the medical side themselves as a parent and as a caregiver. But as they transition, as you want them to blossom and grow, maybe go off to college, start a career, find their space in the world, that transitioning piece is very important. There's another point here, and you mentioned it earlier about missed medications and checking in with your team if a medication is missed. I wanted to kind of circle back to that because I found it very interesting. For me, if I have a cold and I receive a prescription for a doctor, if I miss it, they just say, take it at the next time. But here with a PH diagnosis, you should notify your team if there's a medication missed at a certain time frame or a certain point. That I think that is not something I think of when I miss a medication, but for a patient or for a parent or a caregiver, you're saying notify the team?
Yeah, several of the PH medications, we start at a lower dose and we increase over time to allow kids to adjust to the dose that's best for them based on their age and size and weight. But if they miss a dose or certainly a couple doses, we may need to lower that dose back down and slowly increase it back to where they were before to avoid them feeling really sick from those side effects that can come with these medicines. Each of those decisions is going to be dependent on the medication, on the kid, how many doses they've missed. And that's why it's important for caregivers and parents to talk with their healthcare team if that happens so they can make the best plan for that particular case.
Yeah, thank you for clarifying that because I think it's easy when I am just looking in, okay, you have a medication, you missed it. Let's just move on to the next time you need it. But there are so many different factors that your healthcare team, your medical team take in diagnosing and then prescribing this medication, which I think is an interesting point to know that it is typically a team, right? It is typically a group there to help navigate this diagnosis. So who treats pulmonary hypertension and who is best to treat it in a pediatric patient?
That's a really important question. And I think parents and caregivers should know that it's important to find a team and a provider with experience in the diagnosis and treatment of children. And this is really a case where the team matters. And those team members can include a pediatric cardiologist, a pediatric pulmonologist, nurses, nurse coordinators, nurse practitioners. Many teams will also have pharmacists, social workers, and other members who help them to provide not only guidance on medical therapy, but support for the families and for the kids, again, as they navigate this journey. Oftentimes, children are referred by their pediatrician or their primary care provider, but families can also reach out to contact PH programs directly. And if parents or caregivers have questions or want more information, the PHA provides information on care centers. These are centers that have undergone an accreditation process to identify programs who have a strong track record in caring for children with pulmonary hypertension. And this is a great place to start when you're looking for a care team.
Thank you for making that connection back to the Pulmonary Hypertension Association. Well, PHA is really on the forefront of leading the connection to care, the connection to research, and information that patients and parents may need. Is there anything else as we come to the end that you would like to share out to those listening who have a child with PH? How can they advocate for themselves, or any advice for that parent or caregiver listening?
For the parents and caregivers, I would first of all just congratulate you on listening to this podcast. That already means you're advocating for your child and trying to get good information to help do the best in caring for them. We would want to just emphasize again that while this can be an overwhelming journey, you are not alone. There are lots of resources. There are communities here to support you if that's helpful for you, both with your healthcare team, locally and nationally through PHA and other programs. The other piece I want to emphasize is that we are very optimistic about the future for kids with pulmonary hypertension. We are learning more and more. We are getting new tools, new treatment options, new therapies, and we fully expect to be better able to treat pulmonary hypertension as we move forward. So for your child who's going to continue to grow, we think the future is bright and will continue to get better.
Yeah, thank you. I think that's very encouraging, and it's always good to hear that you're doing something right. So just listening to this episode is a part of that process as well. I just also would like to mention that you are a part of our PACE committee, our Patient and Caregiver Education Committee here at PHA, which brings you all of the resources that you see for patients, caregivers, parents. I'd like to take a moment here to kind of highlight some of the work that you're doing and potentially how people could reach out to you if they're in your area.
Yeah, absolutely. So at Cincinnati Children's, one of the areas we're focused on are better ways to diagnose and to monitor pulmonary hypertension. As we've talked a little bit about today, the gold standard currently is cardiac catheterization. While this is a very safe procedure, it is still an invasive procedure, and we're looking at imaging techniques, including heart and lung MRI, that may give us more information not just about the diagnosis of pulmonary hypertension, but really about what's driving or causing pulmonary hypertension in each child. And so we're using those techniques and developing new ones that we really hope will change the way that we diagnose pulmonary hypertension in the future.
That's awesome. And I know that as soon as you receive more information, we will share out that information as well. So if you want to read more about pediatric PH, you can always visit our website at www.phassociation.org/pediatrics, where we'll have a lot of the resources mentioned here. Thank you, Dr. Critser, for being here today, for being a member of the PHA family, part of our many committees here at PHA. We appreciate you sharing this information for parents.
Angela, it's been a pleasure to talk with you. I hope this will be helpful for the parents and caregivers who are listening.
I think it will. And I think you may get some questions or some exploratory appointments to see. So I appreciate your time. I hope that everyone listening has a great day and join us on the next episode. And thank you for listening to PH Insights presented by the Pulmonary Hypertension Association. Remember to subscribe and to join us every second and fourth Wednesday of the month for more valuable insights.
Thank you for listening to this episode of PH Insights. We'd like to take a moment to thank our sponsors for their support of the PHA Connects program, which brings you the PH Insights podcast. Sponsors do not participate in the development of and do not endorse content of programming. For a list of our sponsors for 2024, please visit our website at phassociation.org/aboutph/sponsors. Thank you for listening.